Hello, good morning. I'm Ashok Rokade, consultant rhinologist and anterior skull-based surgeon from Winchester and the University Hospital Southampton, UK. I welcome colleagues from around the world on behalf of our organizing team to this inaugural Winter Global Rhinology Endoscopic Sinus and Anterior Skull-based Surgery Webathon. Global Rhinology Network is a registered non-profit organization with a mission to foster surgical education in rhinology and skull-based surgery. We have successfully hosted annual multi-center live surgical webcast, The Lioness, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We will have hugely informative and engaging sessions presented by eminent rhinologists and skull-based surgeons from around the world. GRACE 2020 is hosted at the Global Telemedicine Studio of Professor Wilco Groneman in Utrecht in Netherlands. It is supported by Medtronic and Karl Storz. Thank you.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options. With flexibility in hardware design and optional software functionality, get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
So can I request Sam Leong? He's a consultant rhinologist and skull-based surgeon from Liverpool. So he will be hosting for the session with Troy Woodard and Brad. So over to you, Sam.
Thank you very much. I'm mindful of our timing, so I'll have to rattle through the introductions. Dr. Troy Woodard has been practicing in the Cleveland Clinic in Ohio since 2009. He's currently the director of the Advanced Rhinology, Sinus and Skull Fellowship there. Dr. Woodard will be speaking about Vidian Neurectomy for the next 15-20 minutes. Troy, it's a great pleasure to introduce you, and certainly someone from Ohio. I spent a lot of time in Ohio, especially around Akron and Cuyahoga Falls, visiting my grandparents. So it's a blessing to be able to introduce someone from Ohio State. Over to you now.
All right. Well, thank you. Really appreciate the opportunity to present to everyone today. And so today, actually, I would like to present a topic on how to surgically manage a disease that I think many of us see commonly in the office, non-allergic rhinitis, particularly vasomotor rhinitis. And I'm going to talk a little bit about, endoscopic Vidian neurectomies. And when you compare this technique to many of the other techniques that you've seen earlier today, you realize it's pretty simple. And so, but I think it's probably not commonly used. And so hopefully by the end of today's talk, you'll be able to see how maybe this technique could be utilized more frequently in your practice to help some of the patients. These are my disclosures, and they're really not relevant to today's discussion. So we're going to talk about surgical treatment of non-allergic rhinitis, and we're going to do it in a case-based format. Typically, I try to get the audience involved. It's not really possible today, so I'm going to kind of pretend like you're talking to me. So if I look a little crazy, just ignore that, okay? So let's start with a case. Let me move this down here. All right, so let's just pretend you're in the office and you have a 58-year-old female who comes to your clinic, and she's like, "Doc, I have persistent drainage, right-sided, mostly. I also have postnasal drip." And if you're like me, you're like, "Oh gosh, postnasal drip, that's really difficult to treat, right? We always think it's probably GERD or LPR, etc. We're hoping that it's something like allergic rhinitis, but most of the time, it could be something else that it's just impossible to treat." She also talks about bilateral congestion. It's sporadic, but seems to be worse with temperature changes. She also says it's worse when she lies down. And if she eats, she says she has to grab a box of tissues. She has chronic cough, and just surgical history is remarkable for gallbladder disease. So on exam, you look at her nose, copious secretions, pretty much clear though. Her middle meatus is aerated, no pus, no polyps. So in my mind, I'm thinking, all right, so 58-year-old female with rhinorrhea, unilateral mostly. Now, she didn't really talk about salty or metallic taste, but I'm still thinking, could it be a CSF leak, right? She's kind of, I'm not sure what the body habit is in, where you live, but in America, especially in Ohio, we're kind of a little heavy. And so, there tends to be quite a few of, high pressures and resultant CSF leaks. So I'm thinking possibly she could have a CSF leak. All right. We're around the Great Lakes here, so there's a lot of trees, forests. Depending on where you live in the United States, you could have a lot of mold around. And so I'm thinking, is she allergic to the environmental things? So maybe it's allergic rhinitis. And then lastly, if all else fails, maybe she has some form of non-allergic rhinitis. Most commonly though, it's usually vasomotor rhinitis. So I'm thinking, well, how can I go about and determine this, right? So her exam looked pretty good. There was no pus, so I don't really think her secretions are a result of an infection. I don't really think a scan is warranted at this point in time. And so what I did do is do a few tests. And so she was able to actually collect her drainage. So she had enough drainage to collect. We sent it for beta-2 transferrin. That came back negative. Also, in my clinic, we don't do skin prick testing. We would have to refer to our allergist for that, but our labs do RAS testing. And so I sent her for RAS testing, and that too was negative. And so to me, I was thinking, okay, that kind of ruled out a CSF leak, right? Since the beta-2 transferrin was negative. And since the IgE test was negative, I'm thinking it's less likely allergic rhinitis. So more than likely, it's possibly vasomotor rhinitis. So how would you treat her, right? Would you start out with a surgical procedure, or would you consider something more medical? Now, remember, she's already on nose spray. She's already on fluticasone, all right? Typically, that's what we generally use for our first round of medical therapy here. And so the other alternatives that I generally would start with, I would consider a topical antihistamine spray. But in her case, I decided to go something what I think is a little bit stronger, a little bit more drying, ipratropium bromide. That's an anticholinergic. If I'm thinking vasomotor rhinitis, I'm thinking maybe that's the way to go. So I put her on ipratropium bromide, said I'll see you back in about a month to 6 weeks. So let's see what happens. 1 month follow-up. I see her back, still symptomatic. Although she reports partially improvement, still has significant symptoms. So now what? Well, in my opinion, okay, bingo. I think I hit the jackpot because I think I kind of confirmed my diagnosis of non-allergic rhinitis. And when you think about it, you know, I think she has vasomotor rhinitis. So let's kind of narrow down a little bit more on what is vasomotor rhinitis. All right, so non-allergic rhinitis is typically chronic nasal congestion, obstruction, rhinorrhea that is not related to a specific allergen on skin or serum testing. It typically occurs in older people, so usually around, it starts between age 30 to 60, more common in women. And if you were to do a histologic type tissue observation, you will see that there's a decreased eosinophilic response. These people are pretty miserable. They tend to have poor quality of life because they just oftentimes, if you have them in your clinic, they'll talk about how they have numerous tissue boxes all around. They can barely go out to eat because they're embarrassed. They have poor sleep. Sometimes their face is sore from just constantly wiping their nose. The joke in my clinic is many people, you know, they'll say, oh, I should own stock in the Kleenex tissue company, you know? And so the reason why I honed in on vasomotor rhinitis, because that is actually the most common form of non-allergic rhinitis. It's usually triggered by environmental conditions such as the weather, strong emotions, smells, and hormones. And if you kind of go back to our patient's history, that's actually what this patient particularly talked about. It's usually worse when she eats or when she goes and changes of temperatures. I've actually had some patients who said, you know, doc, I'm fine, except when I go to the grocery store and I go down the frozen food section, my nose just runs like crazy. Or if it gets really cold and I go from indoors to outdoors, my nose runs like crazy. That's kind of acute. Now, what's the pathophysiology associated with this? Well, typically there's a dysregulation of sympathetic, parasympathetic, and nociceptive nerves within the nasal mucosa. Now, the mucus secretions is controlled by parasympathetic nerves within the nasal mucosa. The vascular tone, though, is controlled by the sympathetic nerves. Let's look a little bit further into the anatomy of this area. So if you look to the left, you can see at the top, we have a sagittal kind of picture of the Vidian nerve, otherwise known as the nerve in the pterygoid canal, going through the sphenoid, and you have the pterygoganglion in the pterygopalatine fossa. Right? And so within the Vidian nerve, there are two types of nerve fibers. You have preganglionic parasympathetic axons and sympathetic axon, postganglionic sympathetic axons. So the parasympathetic axons actually, they connect with the ganglion in the pterygopalatine ganglion, and then they innervate the lacrimal gland, the nasal and palatine glands. And from there, this is where actually this is what we target. We target this pathway, all right? So it's the parasympathetic nerves that go through this pathway and innervate the glands to cause increased mucus. So what about the sympathetic nerves? What do they do? Well, really, they don't control the glandular secretions. They actually control the sympathetic tone to the blood vessels. How does that interact with the nose? Well, you can have vasodilation, which can contribute to nasal obstruction, all right? And so, again, many of our targets, though, target the parasympathetic complex. Now, if you look at the bottom, you have a coronal CT scan, and you'll see two red arrows. They're pointed at the Vidian canals and the floor of the sphenoid sinuses. This here is actually the target, so that we will be targeting during our Vidian neurectomies. So let's go back to our case. All right, so we successfully partially treated the patient with medical therapy, right? But remember, she still has significant symptoms. So we confirmed her diagnosis as vasomotor rhinitis. She failed medical therapy. So what's our next option? So generally, in most of the things that we do, we try conservative therapy. When you fail medical therapy, then the next option is some type of procedure. Right? And so I'm not really going to focus on the old traditional form of Vidian neurectomies. We're just going to kind of talk about endoscopic versions of the Vidian neurectomy. All right. And so there are typically two types of endoscopic approaches, the retrograde and the antegrade transsphenoidal approach. All right, and so I typically have performed both types of approaches, but generally in different scenarios, and I'll kind of explain briefly. All right, so let's talk about the retrograde endoscopic Vidian neurectomy. This one was actually popularized by Robinson and Wormold, and what they describe is making a mucosal incision over the sphenopalatine foramen. You have to control the sphenopalatine artery, so cauterize that, and then raise the mucosal flap all the way posteriorly to the sphenoid face. Once you do that, then you kind of elevate lateral and inferior. You're going to expose the periosteum and fat of the pterygopalatine fossa. And once you do that, you generally get kerasins. So I usually get kerasins, remove the posterior maxillary wall, and then push all the contents of the pterygopalatine fossa laterally and inferiorly. Why is that important? I don't like to see the contents, right? So I don't want to see the blood vessels. I don't want to see IMAX. I don't want to see any of that. And if I don't see it, that way I'm safe. That way I know I'm not going to get into bad bleeding. So how do I maintain that? I generally stay against the anterior wall of the sphenoid sinus, push and dissect and push all the contents down and out, all right? And so once you get to the area of the Vidian canal, as you can see here, it's circled. You can dissect the nerve and cauterize it, all right? Now, when do I do this approach? Generally, I do this approach when I'm, actually, it's not specifically directly when I'm going towards just the Vidian nerve. I actually do this approach when I'm addressing the lateral recess for like a meningoencephalocele. I actually find that this way, I like to call it a modified transpterygoid approach. So what I usually do will actually approach the sphenoid this way, control my Vidian nerve, and control my sphenopalatine artery, remove the anterior wall of the sphenoid, and then extend it laterally, okay? Now, what does the study show? Well, Wormold found that in his case series, he actually evaluated these patients on a scale of 1 to 10, and they had improvement over average, improvement on congestion and rhinorrhea over average of 25 months. All right, so the next type of Vidian neurectomy is what I typically do when I am just addressing patients with non-allergic rhinitis or vasomotor rhinitis, all right? So this is the type of procedure that I typically do, and it's the reason why I do this type of procedure because I think it's less invasive, and you'll see when I describe it, you really can avoid the sphenopalatine artery and a lot of the other dissections. So I think it's fairly easy, especially because when you use the navigation, really it's just kind of find your sphenoid sinus, dissect laterally, and go. All right, and so what you do is you create a large sphenoidotomy. You control your posterior septal branch of the sphenopalatine artery, and as you're dissecting laterally and removing bone, you remove the sphenoid process of the palatine bone until the Vidian canal is found. Once you do that, you isolate the nerve, resect it, cauterize it, voila. Usually you have to displace your middle turbinate laterally, and it really obviates the need to ligate the sphenopalatine artery. Now, Sue found that patients had improvement in the visual, he graded them according to the visual analog scale. They had improvement over 2 years. Now, out of 414 Vidian neurectomies, he had 3 recurrences over a period of 2 years. So let's just look at a video illustrating me performing the Vidian neurectomy. So again, so I've already started dissecting and opening up the sphenoid sinus. It's pretty simple, kind of created a large sphenoidotomy, controlling the posterior septal branch, dissecting laterally, found my Vidian canal, I identified it with the navigation. Now I'm able to use my drill down. And with this approach, you don't necessarily have to bother with raising the mucosal flaps, ligating the sphenopalatine artery. It just saves time. Now I've ligated and sectioned the Vidian nerve. You can see it within the canal. Cauterize it. Some people use a bipolar. Some people can use the suction bovie. You just have to be careful with the suction bovie, right? And then we just use a little bone wax over it. So again, you know, compared to some of the previous cases, pretty simple procedure that could potentially have substantial benefit to a lot of our patients, right? So what about the complications associated with this? Well, actually our department did a systematic review in which we had, we reviewed 6 studies, and we found that patients, about 23 to 100% of the studies, patients had dry eyes. Most of the time it resolved in 6 months. Patients also reported cheek, palate, and gingival numbness. In about 3 to 22% of the cases, it resolved in up to 1 year. All right. What are some of the other potential complications? Well, remember, you are totally really removing the parasympathetic innervation. So you're going to have less mucosal or like less glandular secretions. So it's going to cause more nasal crusting, which could also cause more scabbing and lead to more hemorrhage. All right. Also, depending on the type of approach, whether you do the antegrade or retrograde, you could have an increased risk of hemorrhage. So you have to be careful with that. Again, I think the you know, the antegrade transfrenal approach does cut down on the risk of injury to the IMAX and the sphenopalatine artery. All right, so briefly, I just kind of wanted to talk on just the new form of therapy since I have a couple of extra minutes. Let's briefly talk about cryotherapy. Could this potentially be a way to avoid some of those other complications? How does this technology work? right? So if you look at the picture to the right, you'll see, again, you see the Vidian nerve going through the Vidian canal, its synapses in the pterygopalatine ganglion, and then it gives off branches via the nasal nerves to all of the different glands in the nose, the lacrimal sac, the palate, okay? What cryotherapy does is it allows you to specifically target the posterior nasal nerves. So therefore, you actually will spare some of the nerves to, like, for instance, the lacrimal gland and to some other areas, all right? Now, other benefits of using the cryotherapy is that it's office-based. And so, you know, you can save on costs. Potentially, you can save on other, you know, just downtime and other, like, just headaches that the patients may have to endure. So this is just an example of me performing cryotherapy in a patient in the office. This is their right side. And so you have the device and you place it in, like, the crotch between the middle turbinate and the lateral wall. The nitrous oxide inflates the balloon and comes in contact with the area and superficially ablates those nerves. After a minute or two, and you can see the blanching of the area. All right. Usually the effect fully takes place after about 30 days. So what does the study show for that? So there was a multi-center study performed recently, and it was a prospective single-arm trial of 98 adults. 98 procedures were performed. They were able to successfully complete 100% of these procedures. They measured the transnasal symptom score and showed that it improved in all time points. They measured the patients at 1, 3, 6, and 9 months after or post-procedure and noticed an improvement in congestion, rhinorrhea, etc. Let's see, they did note, keep this in mind though, they did note, which I think is actually pretty substantial, 29 adverse events. So what are those adverse events? Headache, epistaxis, and sinusitis. So just from personal experience, you know, I've done it, and several of my patients have actually had, I would like to, here we call them like ice cream headaches, so, or brain freeze. And so remember, cryotherapy, if you're not anesthetized appropriately, it can hurt. And so my key is, if you consider this, make sure that you anesthetize appropriately, because, you know, nitrous oxide is very cold. It can be very painful. All right. So in conclusion, non-allergic rhinitis is a common disease that impairs the quality of life in many of our patients. It results from dysregulation of sympathetic, parasympathetic, and nociceptive nerve signals. When medical management fails, targeted surgical therapy via endoscopic Vidian Neurectomy is the treatment of choice. There are typically two types of Vidian Neurectomies that are performed: antegrade transfemoral techniques and retrograde techniques. You should also consider posterior nerve cryoablation. It's a newer technique that has been shown to be effective alternative. Again, thank you for the opportunity to present today, and I'll take any questions.
Thanks, Troy. I'm just going to collate some of the questions, and essentially there's been a lot of chatter in the chat room about how do you work up patients who ultimately have a Vidian neurectomy, i.e. do all your patients typically have an allergy test, CSF testing? Do your patients go for an eye evaluation? Do you want to try and address some of these issues in terms of working the patient up?
Yeah, so I think, honestly, the biggest workup is your history and physical, right? So try to get as a good of history and physical as possible. I usually try to do an allergy workup. Again, it's easy for me to do a RAS test. But then, you know, there's also, not every patient has enough nasal drainage to collect, right? So most of the patients don't have that much nasal drainage. And so I have a lower suspicion of a CSF leak, right? And so it's easy if they say, yeah, I'm dripping out of my nose, salty metallic taste, blah, 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 then that's going to be higher on your list. But if it's not usually it's not that copious amount of secretions. What was the other questions? Eye exams? Typically not. You know, to be honest, only a few patients that I've done have had issues with dry eyes. And honestly, most of the patients that did were happy. They were more happy that they didn't have such a runny nose, that they didn't care about the dry eyes. Does that make sense? And then the dry eyes resolved after several months, though. So that wasn't even an issue.
I totally agree. I think in the workup of these patients who ultimately have a Vidian neurectomy, a lot of the decision making is predicated on a very good history. And then sometimes trying the patients with a combination of nasal spray. And the CSF testing is something that we sometimes beat our backs on, because you're right, there isn't enough nasal fluid to collect for testing.
One thing I would say, though, that, I guess how can I put it? Like in retrospect, you're like, I shouldn't have done that, right? Like when your Vidian neurectomies don't work. So then what? Then that means you didn't diagnose that person correctly, right? And so, in my opinion, and then it turns out I've had a couple of cases where it didn't work, and then I found out, I should have really gone down that LPR GI issue a little bit more than I did, if that makes sense. Yeah. And so I don't know if you encountered that at all.
They are not common, though. I was going to ask you about alternatives to Vidian neurectomy. So say you had a patient who felt that putting oneself through a Vidian neurectomy procedure was a bit too much. Would you consider, say, submucosal reduction of the inferior turbinate just to try and provide, a reduction, albeit very subjective, a reduction in nasal discharge? Is that something you would consider to offer?
Right. So right now, my current regimen, I offer two things first prior to a Vidian neurectomy. Well, three. So obviously the medical management first, and then I try the cryotherapy. I also I do a lot of radiofrequency ablations in the office, so not necessarily submucosal like tissue reduction, physical tissue reduction, but I do radiofrequency ablation with and so that seems to help too. And then if all of that fails, then we talk about the Vidian neurectomies, but it's usually a stepwise progression. Yeah.
My practice, certainly mirrors what you do as well. Another question here, in the antegrade technique, do you stabilize the middle turbinate at the end of the procedure?
So yes, so I usually, I call it bulgarizing, but yes, usually what I do is just kind of make a controlled synechii, and then I'll put like either some type of dissolvable packing in the middle meatus to keep it medialized.
Okay.
Does that make sense?
And then a final question. You use the Bovie suction monopolar, and do you think the incidence of complications may be linked to the type of instrument that we use, say, say a comparison between, say, cold steel, monopolar, or coblation, which is what I tend to use for my Vidian neurectomies.
You know what? I have read that there was a decrease in incidence in complications between monopolar and bipolar. Honestly, I think it depends on what you have. So I use kind of what I have. And our coblator is a little bit too large to fit right there. But I'm interested in hearing your thoughts. I haven't really, if you have a wide open spot, I just don't keep my suction bovie just buried in there. I just kind of do judicious cautery. So I think it's okay. But what about your complications? Have you encountered many?
Certainly, it's all anecdotal because I'm trying to get data, meaningful data from these patients. And a lot of the symptoms pre and post-op tend to be quite subjective. How many boxes of Kleenex do you use before the operation versus how many after? And similarly, how wet was your eye before and after? All very, very subjective. But certainly anecdotally, I have noticed less patients complaining of a dry eye when I transition from the suction monopolar to the coblation. I totally agree. The coblation, the coblator one is a bit more clunky.
Yeah.
And it's difficult to sometimes manipulate the surface, the active surface onto the Vidian nerve, even after you've exposed the canal as much as possible or remove the bone around the canal as much as possible. But certainly it's just anecdotal, really.
Okay, I may have to try that. I've read that though. Well, thank you.
Thank you so much. Troy, can I ask you to have a look at the Q&A? There are a couple of questions there. And maybe you could address some of those questions. And I think you've already had addressed some of those in our conversation, but I'll move on if you don't mind.
I can't, I'm not familiar with the oscillation system.
Okay, so let's answer it. Electrocoagulation, that's a little bit like radio, I suppose a wee bit like radio frequency, isn't it?
So the Vidian neurectomy, the Vidian neurectomy is a little bit more proximal resection. The posterior nasal is more distal resection, so it's more targeted. So you make an incision, for instance, some people can make an incision right above the inferior turbinate. So therefore, it's more targeted to where you don't have as many side effects, for example. So like I mentioned, the cryotherapy, that's targeted towards the posterior nasal nerves. And so oftentimes people who have those nerves ablated don't have the side effects of the dry eye. Hopefully that answers that question.
Thank you.
All right.
Thanks so much, Troy. I'll move on now.
The head and neck surgeries you perform are vital. Your patients place their trust in you. You help them continue to speak and smile, eat and drink, hear and comfort. You're committed to helping them continue to live fully, to feel deeply, and to enjoy the quality of life they've come to expect. That means being confident that you're protecting and preserving your patient's head and neck nerve function during procedures. Introducing NimVital, the next generation of nerve monitoring technology. NimVital provides advanced nerve monitoring that helps you reduce the risk of nerve damage during head and neck procedures. Detailed intraoperative nerve condition information helps inspire your surgical strategy. An intuitive user interface with a wire-free patient interface allows for easy setup and enhanced visualization from the surgical field. Real-time notifications of nerve conditions, visually and audibly. Green, yellow, and red status bars provide visual information, and their associated tones provide audible cues, making monitoring function easier than ever. NIM Nerve Trend EMG reporting enables nerve condition tracking throughout a procedure, even when using intermittent nerve monitoring. And when paired with a NIM continuous monitoring electrode, you have continuous nerve monitoring informing your surgical strategy. NimVital pushes the boundaries of monitoring nerve function in various procedures in head and neck surgery. with real-time information available during surgery, giving you confidence in nerve function. Because protecting patients' nerves and senses is more than vital. NimVital.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options. With flexibility in hardware design and optional software functionality, get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.